Well, I hope you enjoyed your evening and glad to see all of you back in the room again for our second day of conference. I want to take this opportunity to make a couple of announcements and thank a couple of folks. First of all, I really want to thank the organizational team that we have here. You've already met them. Annalise Cothran, from AAPHD, Dr. Francis Kim, and Dr. Shohini Dar have sort of kept the whole thing running for the past day and a half. So, and appreciate their work on organizing this day. So please join me in thanking them with a round of applause. Just a couple of other acknowledgments. The American Institute of Dental Public Health is overseen by a board of directors. And we have a great board of directors who are very insightful and give us great guidance and lead the organization, the direction for the future. And I do appreciate them and want to acknowledge their work. Beverly Eisman, Dr. Caswell Evans, Dr. Karen Yoder, Dr. Howard Pollack, Dr. Raul Garcia. Thank you all very much for your work on the board, your guidance and direction. It's very much appreciated. Lastly, I want to just make a couple of announcements. So we can recycle the plastic. So at the end of the conference, if you want, please give us out on the desk your name badges and we can recycle those at the end of the day. The most important thing though is your evaluations. So, we read those evaluations and we make adjustments for the colloquium next year. Things you like, things you didn't like, things that worked, things that didn't work. We really appreciate your input and your direction. So I would ask you to please give us your evaluation forms back, and those will be available. Your evaluation forms are in your packets, and you can put them out on the registration table. There'll be a basket available. Where? Oh, for those of you who want CE credits, yes, please complete those forms. Right, and put them out there. So, any other housekeeping issues? We got them all? Good. Okay, so let's begin the interesting part of the day. Our first speaker for this morning is Evelyn Ireland. Evelyn has been the voice of dental benefits industry for 26 years as the executive director of the National Association of Dental Plans. She has more than 32 years experience as a trade association CEO and over 45 years in the area of government and insurance. Ms. Ireland has a varied career, starting with the Texas legislature, where she worked with the chair of the insurance committee before moving to the Texas State Board of Insurance. She worked for Texas Senator Lloyd Benson in his U.S. Senate office and as a lobbyist and is the executive director of the Texas HMO Association. Ms. Ireland has a BFA from Texas Tech University and a master's degree in public affairs from the LBJ School of Public Affairs at the University of Texas at Austin. She completed a portion of her work at Harvard's Kennedy School. Ms. Ireland has earned a certificate from NAIC, Commissioner's School of Insurance, and maintains the CAE designation. Her presentation today is Exploring Paths for Dental Integration and Coordinated Care. Please join me in welcoming Evelyn Ireland.
I guess I didn't fully update that because it's actually 27 years now, starting this year. And this year will be my last year as executive director, as I've announced my retirement my first retirement, Jack. As Jack and I were talking about, retirement just means you're going to do something else. So hopefully I'll find something else to do that'll be useful with all of this information that I have gathered in my many, many years in the insurance industry. I have to say that at first I wondered when David had invited me why it was I was being invited, because I'm a trade association executive in the dental benefits industry. I see things at the 10,000-foot level. I look at the market, and mostly on the commercial side. It's only recently, with some of the growth in public programs, that the organization has gotten more involved in the public side of benefits. But he assured me he wanted me to come. And after sitting through the presentations yesterday, I realized that there is actually a lot more information that NADP has and perspectives that we have that can be useful in answering the questions that, some of the questions that you posed yesterday. So yesterday, after the first Q&A session, I actually pulled Annalise aside and said, okay, so can I change my presentation? Can I add some things? And she said, yeah, if you get it to me so we can load it. So I've actually gone through and added information on some of the projects that we have underway that I think will be useful to you. And additionally, I learned a lot yesterday that I think I can help translate to the dental benefits industry in bringing them more information on the things that you're involved in and the interests that you have and some of the things that they could do to improve in interprofessional development and the delivery of care. So, you warned me about pushing the button too hard or too fast. So I'll try to keep on with the slides. Some of you have known me since I started with NADP. I think Jack is one of the first people that I met at one of the early conferences, and it wasn't actually NADP back then, it was NAPDP, the National Association of Prepaid Dental Plans. So it was only dental HMOs when I started. So much more like some of the discussions that we've been having, that we've been having in the past day. So, but there has been a great change in focus of the organization and broadening of the organization. Today, NADP's members write over 95% of all the dental benefits in the United States, both commercial and public program benefits. I thought it might be useful just to give you a couple of slides about NADP. This is our mission, and you note that I underlined the advance part. Yes, we defend the industry, and we work a lot in government relations, but I take very seriously the part of the mission to advance the dental benefits industry to provide access to affordable quality dental care. I remind the staff and our members of this mission every year at our leadership conference. It's no surprise, probably, any trade association is going to work in government relations and research. We do a lot of original research on the industry. We have a series of benchmark reports that we do. We do education and communication. I think David said I'm the voice of the dental benefits industry. The ADA and other organizations refer reporters to me all the time for information on dental benefits. But one of the things that we do that I don't think is very well known or understood is something we call, just for lack of a better word, just collaboration, but it really is work on standards, terminology, and transactions. NADP actually serves on all of the standard-setting bodies that touch the dental benefits and dentistry, the practice of dentistry. We sit on X12, HL7, SNOMED, DQA, the CMC, the Dental Content Committee. So if it has to do with claims, codes, diagnostic codes, quality measures, we're participating in all of those with either a member, well, with both a member of staff and volunteers. NADP works through a series of committees and volunteers. We have, I think this year, I think the number, because we're getting ready for our leadership conference next week is 356 volunteers that serve in 537 roles. So most of them do more than one thing, sit on more than one committee. And some of those are working on projects that you probably have never heard about that I think touch directly on some of the things that you're interested in. So I'm going to skip through a lot of the slides in the beginning of the presentation pretty quickly. Somebody else's pen. And they're in the slide deck if you've got questions about them, either during the program today or after the program. Feel free to get in touch with me and ask me for more information. You saw the learning objectives, so I'm not going to go through those, but I wanted to start with dental enrollment trends, because this is really a big story in the last several years. Currently, only 22% of Americans have no dental benefits. This is a big change since the 2014 introduction of the ACA or implementation of the ACA. While just over half of the population gets dental benefits in the private market, primarily through employer groups, more than a quarter of the population now gets dental benefits through publicly funded programs. This is a combination of things. It's a combination of Medicaid, and that's the biggest part of it. But there's also growth in CHIP and Medicare over the last several years, and I'll go into quite a bit of detail about those. The interesting thing that I did with a reporter in December was to kind of dig down into who the uninsured are. Who is that group that is the 22%? And interestingly, a third of those are seniors, and we talked about that a little bit yesterday, and I'm going to offer some additional information on the coverage of seniors. Most of the rest of them, as you'll see in some of the other slides, are in small employer groups. A lot of them are employed and don't have access to dental benefits. And then, of course, there's a population still to be reached with the Medicaid program. If anybody has a question on this slide about what private non-group means, that just means individual coverage. So this shows you the trend over time. This is from one of our research reports that we do every year. And you see a big jump beginning in the 2014 time frame through to today. And the bars are divided into two parts because the commercial sector is the dark blue sector, and where you see the most growth is in the public program sector, which is depicted in yellow on the chart. So you can see that coverage really hovered in the 60% range until the implementation of the ACA. And I don't want you to think that those big jumps year to year in the 2015-2016 timeframe are all just improvements in coverage. To some extent, what the ACA did was make better data available to those of us that dig into numbers and look at research. So part of that change in knowing about the population covered actually came from better data from CMS. So we mine that data to add to the data that is reported by the industry. This is way too busy to see on a slide, but I wanted you to know that this data is available. And what I've circled down there at the bottom is the big expansion in the population in the publicly funded programs. This data actually tracks back all the way into the early 90s when I myself collected data from members of NAPDP and had to convince them to submit that data. But we've improved tremendously over the years in being able to track segments of the market, and in the last several years digging into the CMS data to supplement the data on public programs. Between 2014 and 2017, the population with benefits through Medicaid, with dental benefits through Medicaid, more than doubled. And the population with dental benefits through Medicare Advantage programs more than tripled. So those are the two sets of numbers that you see there. CHIP enrollment has also increased, and I've got some more detailed data on that later. So I wanted to talk a little bit about the impacts of oral health on overall health, and this is the part of the presentation I was telling John this morning that I'll probably sail through because you guys know all of this. You know it, and you were talking about it even before our industry was really talking about it. In many ways, the Surgeon General's report, which Kaz was and many of you were, that I probably don't know were very involved in developing, really changed the way we talk about oral health. It first really brought to the public eye, I think, the connections between oral and overall health, and it started a new dialogue. The commercial dental benefits industry had been doing, are they trying to tell me? Speak louder, go faster. Oh, really? Our industry had been doing studies, the commercial side of the industry had been doing studies on the linkages and using it in marketing. But it really became clear that the links were important because of the I think there are really four major areas of research where the impacts on chronic disease and high-cost medical conditions were identified. And what this shows is the cost of treatment in these four major disease categories where there's been a lot of research done. One is newborn, low birth weight babies, of course, diabetes, cardiovascular disease, and stroke. So those are not surprises to you. The commercial industry continued to do studies, and I've got three of the companies that participated in a webinar that we did for the industry, I think a year ago. I've pulled some of their slides just to show you. There are many, many more, and we're actually today submitting a letter to I don't really remember where we're submitting it, but it's to provide input for the revision of the Surgeon General's report to give some of the data that we have, and we have a more of an index of all of the recent studies in that particular letter. And if you're interested in that, I'm sure it'll be public anyway, but I can certainly provide it for posting as well. So these are three companies that do quite a bit in this space. They've published more studies than this even since these were written. United Concordia is one that has done quite a bit of research with Jim Bramson's tenure there. They really have focused down on this area, looked at the total medical costs for, again, diabetes, cardiovascular disease, stroke. So they found the savings in the total medical costs, in addition in hospital inpatient admissions, and they summarized it in a slide that was pretty accessible to the layperson in terms of the overall annual dollar savings for these different conditions when there was periodontal treatment provided to the population. And you can see that the savings are anywhere from $1,500 or $1,000 to $5,600. So those are significant. Aetna did a little different look at it, and not in terms of the dollars saved, but looking at the improvement in risk scores for chronic conditions. That last one was on coronary artery disease, and this one is on pregnancy. Oops, I didn't realize that they built in, you can see I saved some of the slides, but I didn't realize they'd built in the animation. So this was the savings, and this one was interesting because this wasn't focused on periodontal. A lot of the work that has been done on adults was focused on periodontal. This particular study was done actually just on preventive, delivering preventive care. And in delivering preventive care, they still found significant savings in medical claim costs and hospital admissions. This particular study actually started us on the path to do a study related to the public health sector, which I'll mention in a minute after I show some of Kaiser's research, which this is all focused on diabetes, where they showed the ability to control blood sugar and reduced costs for in the diabetic population as a result of periodontal interventions. And I told you I was going to flow through that because I think you probably have this information and more. That information is all focused on the commercial population. It's not focused on the public health population. In 2016 and 2017, when the Trump administration took over and there was a lot of discussion about block granting Medicaid, we became concerned about how to defend the adult dental benefits that had been added under the Medicaid program and wondered whether there was any data that was available or could be mined in public programs. So we commissioned Dr. Mansky and his colleagues at the University of Maryland to do a dive into the MEPS data, the household survey data that is available for that. Really, there's been a lot of dental data that Dr. Mansky has dug out of that particular database. We weren't sure we would find anything, and of course, the Medicaid population has not been provided a lot of periodontal benefits, so we knew we couldn't look at periodontal, but the Aetna study made us hopeful that there was a possibility of finding similar information with just preventive care delivered to the Medicaid population. We were surprised that what we actually found in the very same set of disease categories, we actually explored quite a number of them, but looking at coronary heart disease, diabetes, even high blood pressure, stroke, we found anywhere from 37% to 67% lower costs in the Medicaid population that had received preventive dental benefits. That to us was, groundbreaking, historic. So we published it at the end of 2017, and we talked throughout last year about what additional data could be mined from MEPS. This data is from 2014. That was the first year of Medicaid expansion. And of course, with the expansion of adult dental benefits, we knew we wanted to do subsequent years, but we had to wait for that data to be available. What we actually have done in the last 60 days is the University of Maryland didn't have the bandwidth to go back and do more research right now. So using some of Aetna's connections with Columbia, we've hired Columbia to actually replicate this 1 year of data, which they've already done, and have worked with Dr. Mansky to make sure that everything is being pulled the same way. And we are going to pull 2 more years of data so that we have basically trend data, hopefully that shows the same thing. And with trend data, we can produce a journal article that then can be better utilized as not just a single point in time, but a trend that this happens over and over and over again if you just continue to provide those dental benefits. So hopefully we will get the journal article done this year, but I know we'll complete the research and we'll be able to share it with you all as you need it. I'm participating in a group that meets every couple of weeks. I think that is funded in part by DentaQuest, just to discuss adult dental benefits and the work that is going on, and we're presenting this work to the group. One of the things that all this research has done is convince employers that dental benefits are essential or a differentiator. There's only, over time, and this is employer research that we do, only about 10% of the employers that we touch in any one of these studies don't think that dental benefits is important. So 90+% of all employers believe that dental benefits are important, and they understand the connection, they've heard the connection, they can repeat that to you. Unfortunately, their knowledge that dental benefits is important doesn't always translate into them offering or continuing to offer dental benefits. This is just showing the trend since the ACA was introduced in employers of all sizes. You see 3 groups there, the under 50 employees on the left, and then in the middle 50 to 100. And the reason we use those breakdowns is they're breakdowns that are used in the ACA, and then over 100. The overall trend has been down. And it's not because they don't recognize the value or that consumers don't want dental benefits. It's because of all of the costs and pressures under the ACA relating to health coverage. So there has been some erosion in the market. If we went all the way back to, in terms of employer offerings, if we went all the way back to that slide that had the blue bars and the yellow bars, you wouldn't have seen a downturn in the commercial part of the market. And that's because the small employers don't represent a large portion of the population, and there have been enough gains in the other sectors that we actually have gained several million in enrollment since the beginning, in the commercial sector since the beginning of the ACA. But unfortunately, what we've seen is a shift from the small employers in terms of the population covered more into the large employers. So it's not an overall loss of coverage, but there is a shift in who is being covered in the commercial market. So we've got quite a bit of data that we actually have paid Avalier and other researchers to dig out of the CMS data related to public programs. So I thought it might be useful to go through some of the detail of this for you. There have been about 73 million individuals, or there are, as of October 2018, 73 million individuals covered under the Medicaid program, and 16.3 million of those have been added since the ACA. Of course, the biggest part of that is the ACA's expansion of Medicaid to 133% of poverty. So this is the latest update to the map that shows the states that have expanded since the 2018 midterm elections, since there were referendums on several of the state ballots. We now have 36 states plus the District of Columbia that have expanded, and there are a couple of states where the governors are maybe key, actually, in adding to expansion this year. And of course, the reason that that expansion makes a difference is because of the good work that many of you have done, and I think the community overall works toward expanding Medicaid benefits to adults. Since it is optional, it is a lot of work on a state-by-state basis to get those benefits added. And where we stand right now, and this is again the most updated map that was published in November of 2018, is 18 states and DC with extensive benefits, and 17 states with limited benefits, and only 3 states remaining with no adult dental benefits. So when you combine those, and I think you all know the definitions of what extensive and limited in is, but when you combine all of that, you get that doubling of the population covered under Medicaid since the beginning of the ACA. Of course, there are challenges to Medicaid expansion, and that's one of the reasons we're doing the research that we're doing on the impacts of adult dental benefits to the other costs under Medicaid. And the challenges are really the expanded reasons for getting waivers and the opportunities to impose work requirements and other limitations on the benefits that could harm or reduce the population that we see covered. This is from Families USA. I'm sure you're familiar with it, but if you're not, they have a wonderful strategy center on waiver activity with resources on how to oppose those that are negative, to have a negative impact on oral health. I mentioned growth in CHIP, and probably one of the best things that the entire oral health community has done in recent years in Congress is to get the funding of CHIP extended through 2023. So we don't have to have that conversation every few years about funding of CHIP, and can just have those programs operating in the various states. This just came out this week, and I don't know if this is a resource that you all are familiar with, but because we do a lot of work in the public policy sector, we track work that is done by the National Academy of State Health Policy and several other national groups. But they just published this report, which does show CHIP improvement projects and performance measures across the various states, those that are in place currently. So if you haven't seen this, I think it came out 2 days ago, it probably is a resource that you would want to access. So talking about the Medicare Advantage segment, and maybe this is not a segment that you know as much about. This is one of the areas we had Avalier research for us in 2017. Medicare Advantage products are currently over a third of all Medicare enrollment for those over 65. And by 2027, it's expected to be more than 40% of the enrollment in Medicare. So one of the things that Medicare Advantage does provide to the senior population is dental benefits. More than half of the Medicare Advantage products have what is called a mandatory dental benefit. And the mandatory benefits are actually, that just means that they're always included. The mandatory benefits are usually paid for by star rating money that the Medicare Advantage plans have earned. So they do an add-on benefit, and vision and dental are usually the first two that are added. There actually, interestingly, is a little more vision than there is dental, but that may be because of the lower cost. But dental is definitely one of the first added, and then that orange bar you see there is the additional percentage of plans that have an optional benefit, and the optional benefits have an additional premium. So they're usually more extensive. The mandatory benefits most often are benefits that just include prevention, but at least it does get the senior into the dental office. So it's about two-thirds, a little over, about two-thirds of the Medicare Advantage plans that have dental benefits added. This is the distribution of how those benefits are offered across the United States. The orange and the darker blues, you look down at the southeast and the east kind of portion of the map. That's where more of the Medicare Advantage plans with dental are offered. And this data is from 2017. The interesting thing, if you look at that map, which is very heavy on the east side of the United States, is that the highest percentage of enrollees in MA plans with dental coverage are not in those same states. They have a tendency to be more they're really more scattered across the United States, but they definitely are as much in the north and the Midwest. So it must be that the plans, even though there are fewer offered in those states, have a higher take-up rate. So the distribution doesn't exactly match the offering, but the distribution is fairly positive across the United States. We did a little digging also because there's data there where you can look at actually the types of services that are covered. Of course, the preventive services are the highest in terms of covered, and this is related to the population, not the plans. So this reflects how much of the population has the different coverages. And then you can also dig into how the services are paid, whether there's any kind of coinsurance, and pretty similar to commercial coverage. Preventive services usually don't have much in terms of out-of-pocket costs. Now, this is the piece that I think you're really interested in, and this is kind of a conglomeration of some headlines, but I wanted to talk about it maybe in a little more depth. And Jack, I think you said yesterday that you are on the Pacific Dental Services Foundation Board. So I have no doubt that you had a hand in this because that foundation actually commissioned Avalier, which we're a fan of that particular research group. They do a lot of policy research, and they're very well respected in Washington, to do a study of the impact, the estimated impact of adding dental to Medicare Part B. And if you haven't seen it, I can provide a link to that particular study. But in very broad terms, basically a $7.2 billion investment on the part of Medicare to treat periodontal disease in adults would net $63.5 billion in savings over 10 years. I think this was commissioned for a Santa Fe group discussion, and then that group took it to the ADA, and it's been published in the ADA journal. But this is kind of the surface of what's going on the surface. What's going on deeper is that you talk about it at the policy level, and of course you have to talk to members of Congress, and there is discussion about this addition, not under this administration, as we all know, but just in preparing for the future. One of the most promising things that has gone on is the Congressional Budget Office, which the Congressional Budget Office is the group that actually has to do this very similar kind of estimate about legislation. The Congressional Budget Office asked to meet with several of the key researchers that have done some of those commercial studies and just dig down into their knowledge about the savings and the impacts and what they have seen. So the Congressional Budget Office is preparing itself to do that estimate. And they don't, yes, these are policy wonks that are way down in the bowels of the government, but they don't prepare for things and spend their time preparing for things if it's not something that they think is possible. So I thought that would be a really interesting piece of news to you, that there is that kind of activity going on in preparation for, at some point, a change in administration. So progress in terms of, there still will be progress in terms of the MA plans, but a bigger policy discussion ahead about the addition of dental to Medicare Part B. So this is probably the section I'll spend the most time on. How am I doing? I'm doing good, right? Okay. I'm skating through this. It's no secret to this group that the connections between the dental contributes to some of the costs on the medical side, certainly through ER visits, which I'll give our volunteer, Matt Sennett, who's with Willamette, credit for this slide, because this is part of a slide presentation he shared with me. But it's like all this stuff on the right is what happens in terms of emergency room visits. But all of the opportunities are on the left, and this is how dental could contribute to other reductions in costs by seeing and referring people from a dental office to a medical office, seeing people that are not always seen on an annual basis in a medical office. So if there are these kinds of large opportunities, how is the stage being set? What is the action on those opportunities in the commercial sector? This is a very high-level look at a survey that was done by West Monroe Partners for one of our general sessions at our conference a couple of years ago. And they were looking specifically at the future of standalone dental and the stage for medical-dental integration. The first set of numbers across the top is a focus on health plans and what they intend to do in terms of dental benefits. And basically what it shows is that they intended to aggressively focus on dental benefits as an ancillary or an additional benefit, and that they are currently offering those products either through a subsidiary or through an agreement with another standalone plan. In the middle are the factors that were cited by both medical and dental carriers as the factors that will drive embedding of dental benefits into health insurance. The number one factor there, interestingly, the 62%, is technology. That better technology will facilitate a holistic approach to healthcare. Government mandates were another factor. If that happened, then a government mandate would trigger the embedding. Certainly it did with pediatric benefits, but not always actually in the majority of the time, not in a good way, because the pediatric benefits that have been added in the commercial small group market are largely subject to the medical deductible, which means that there really is not a benefit there. And then just the third factor they said was overall convergence. Then the last set of questions that were asked was, who has the advantage in the dental benefits market? And both dental benefit executives and health executives said health executives do. They're the ones that could do this. So a really interesting piece of research because it pointed to medical plans intending to act quickly and aggressively in adding dental benefits. Just as an aside, since I have a few minutes, I wanted to mention that last night I went down to the bar to get dinner, and a couple sat down next to me and we started talking. Turns out that they were from a conference that just ended here, which was on health IT. And so he asked what I was doing, and I told him I was giving this presentation this morning. I said, let me ask you a question. Have you ever been asked about putting dental into your IT platform? Because he was telling me that they have platforms that serve the hospitals and the medical industry. And he said, we get RFPs like that all the time that ask us whether we can do that. He said, but we don't respond to them. And I said, well, why not? Why have you never done this? And he said, I guess it's the return on investment. We're not seeing that there's enough of a demand, or that it's too difficult, or we have lots of other priorities. And the lots of other priorities is what I get from the health carriers quite a bit. But that health IT piece, when we talked yesterday about externalities, it's not just in the insurance industry, it's the health IT industry too, that there's a nut that has to be cracked there. So this is where the system stands today. So on the last slide, medical carriers said they're going to aggressively get into embedding dental benefits. We track every year how much of the business is groups, standalone individual, medical writers, and other is basically the line for direct reimbursement that you barely see up there. But I had our research director put the percentages there at the very top in terms of the percentage of total benefits that are embedded. and you can see it's ranged from 1% to 3% over the past several years. So the action in terms of aggressively going into dental benefits is not necessarily embedding. What they do more typically, the multi-line carriers, is bundle dental and medical together to sell. And I've talked to several of the carriers that do this, and what they actually do reduce the medical premium based on their projection of savings from having the two coverages together. So they bundle it rather than embed it. And part of that is just the separate delivery system, separate claim form, separate coding. It's too much for a medical carrier to necessarily invest in on their own. They want an SADP, a standalone dental benefits partner. Another reason embedding hasn't happened is consumers are happy with their dental benefits. They see them, they're accustomed to them being separate. And actually there's some studies that have been done by a couple of the carriers that have embedded benefits that show that there's actually lower utilization when benefits are embedded. So at the very least, if we went that direction, there would have to be a good bit more education for consumers to utilize those benefits. Another reason is that benefits have stayed separate is the premiums are very low and they haven't really changed % or so over the last several years. And actually, when you take into account inflation, that means that premiums are actually going down. And this is interesting because more of the cost is being shifted in the commercial sector to the consumer, and despite that, the consumer is still active in buying and supporting dental benefits. So yesterday we talked about how important IT and electronic transactions are in terms of one of the facilitators of change in terms of interdisciplinary care. This looks like a positive story because we had a jump in the a surge, really, in electronic claims in the small carriers. The group of carriers on the left are those with 1 million or less claims. The ones on the right are more. And we had hovered in the low 60% again, but it has been going up a little bit steadily. But even in electronic claims, while we're in the 2/3, in the medical arena, they're north of 95%. So the ability to do things on an and claims is actually the highest percentage. If you look at remittance and you look at payments, it's much, much lower. So dentistry is still below where we need to be in terms of participating in electronic transactions. With the cost of dental and limited resources, we do need to be cautious in terms of what we add in administrative expense and measurement. And I just wanted to make a note of the DQA's activity, since we're on the executive committee of the DQA, that when you do look at measurement, using measures that have already been tested and developed for our industry, is probably the best approach. And I'm preaching to the choir because if you look at who uses DQA measures according to DQA itself, because this is a webinar they did for NADP, it really is public programs that are using the measures now. I did want to yesterday there was some mention made that DQA is involved in diagnosis code development, and that's what I want to spend my last 5 minutes or so on. They're actually not. That's outside of DQA's purview, but some of the same staff at the ADA are involved. And I wanted to give you a little tour of what we've seen going on in diagnostic coding and where we see that going and what the key impediment is to really collecting and compiling more diagnostic data. Again, I pulled some charts from This is from a presentation that Elspeth did for us on diagnostic coding. And one of the problems that we've had actually with diagnostic coding is that the educational system and the ADA developed two different systems, and those were very separate for a long time until really kind of in the 2014 timeframe when the ADA licensed their code, their SNODENT codes, which had really not been utilized or really fully released, to what used to be called ITSTO, the International Health Technology Terminology Standards Organization, but is now called SNOMED, so that makes it easier. After a lot of back and forth in the discussion in SNOMED about how to develop codes, these two systems have merged. And I'm assuming everybody knows that, but it's now called SNODDS, and that full merging didn't happen until 2017. So having the full merging of the set is one of the presets for really implementing diagnostic coding. Now, while this kind of merger was going on, there was other activity at SNOMED to work with diagnostic coding. SNOMED actually has a group called a Dentistry Clinical Reference Group. NADP, again, is a member of that group. And what they've done is they have been taking these, I think you saw on the last slide, if you could absorb that quickly, 1,700 codes, and looking at them by specialty area of dentistry. They started with the general dental codes, and they're reducing them to something that is a more usable set in the 50 to 75, well, probably a few more in general dentistry. They finished general dentistry, and they've created a crosswalk of those codes to ICD-10. ICD-10 comes in on the claim form. These codes actually go in the electronic record or in the record and should be mapped by the practice management system to the claim form or ICD-10. So SNODDS goes to ICD-10, goes to the dental claim form. It can happen on paper or electronic. The problem that we have, and we actually had inside of NADP, separate from the group at SNODENT, a group that was working on something we called the Big Data Project. And the idea of the Big Data Project is that at some point in the future, we all will be getting these codes, and when we do, they need to be compiled somewhere so that we do have a population database. That project looked at all of the steps we need to go through to get to use of diagnostic coding. And their education was the beginning. What we identified actually is that the practice management software for the most part, doesn't have a place for diagnostic coding. And because they don't, we can't always really get it on the claim side. And that's a real impediment to moving forward. So one of the things I wanted to tell you is the ADA had an administrative summit in August. There were a number of issues that we discussed, but one of the main reasons for having that summit was to bring in the practice management vendors and to have this discussion. Why are you not doing this? There are a lot of, even if they did do it, and we actually got a commitment through our Big Data project from Henry Schein to add diagnostic coding to their cloud-based system when that gets published. But dentists don't really update those systems. They don't buy the latest software. They don't go to the cloud-based version. So we've got a lot of education to get dentists to use the codes before they could be required. Somebody asked the question yesterday, why don't the insurance companies just require it? This is why. Most of the products are network-based products. PPOs are over 80% of the market. If you know that dentists don't have systems that can report, and dentists are important to your product, you can't really require them to do it. So what has to be done, and that's what this big data project has been working on, is we have to get the codes into usable sets, which the CRC group is doing at SNOMED. They have to be crosswalked, and then you have to get the practice management vendors to implement this. So we're working on all of that behind the scenes with the ADA. It's like watching paint dry or glaciers. I can't say glaciers melt anymore because, because glaciers are melting too fast. But it is a painstaking process, a lot of discussion with practice management vendors. But it is work that is happening. So it's not one of those magical, we can just require it. A very large, I'll tell one last story. I had a couple more slides, but maybe I can use those when you ask me questions. I'll give you one story. Our board of directors meets every year with the ADA Council on Dental Benefit Programs, and we have a high-level discussion about issues that are going on between dentistry and the commercial industry. There was an issue this last year about one carrier that decided to require that all payments would be made electronically. Everybody was going to do that by, the end of next year. And the pushback from the networks was awful. That carrier had to back down from really fully implementing that, and in order to keep their network robust. If you don't have a robust network and the next guy does, you lose your business to the next guy. So, there's business involved in all of this. But what we did was start with the ADA a series for dentists that shows what an electronically enabled office is able to do and what the steps are to get them to accept electronic payment and what a paper-based office is like, and giving them kind of real, on their level, information about how to move to the next step. Again, painstaking, but work that has to be done. So I think I'm to the 15 minutes or 10 minutes or however many of questions. And I will just say, we do get some diagnostic code data. We've got data that shows that 25 or so companies are getting it, and they're using it in risk-based benefits. So the incentive to submit it from the dentist is that they get paid additional money for conducting risk assessments. So, yay, So hopefully the revisions to my presentation gave you some answers to some of your questions. I couldn't just stand up yesterday and give you the answer that you needed to that question because it took a little more explanation. So, and thank you for letting me change my presentation at the last minute. I know that's not fun.
Look you up here.
Yep.
We do at AIDPH.
Okay.
Any questions or comments?
So I just have a general question. Maybe you can answer, maybe you can't. Just if you think about the way dental benefits are designed, sold, adjudicated, claims are paid to providers, and you compare that to medicine, generally speaking, would you say we're 10 years behind, 15 years behind? Like we're living where that world, especially with the evolution of ACOs, bundled payments, DRGs, the way that over the last 25, 30 years played out. Because we often talk about in Kaiser this, like, where are we with regard to technology in our dental lab? Are we 5 years ahead? Are we 10 years behind? Because 15 years from now, what we do now is going to determine how well we can provide care and be strategically positioned. Would you say dentistry is decades lagging in our ability to actually pay for services in a way that this organization, like this group, has been talking about? Or are we right there, or are we ahead? What do you think? And what's your perspective as a leader on moving the profession forward?
I would love to say we're ahead. That's not a realistic response. We're not decades behind, but we are behind. one of the things, if I had access to all of the data, I'd throw it up here for you, but one of the things that the dental benefits industry has done in a way to kind of shoot itself in the foot is we're very efficient at paper. We can actually push a lot of paper and do it fast, and we can pay claims almost as fast on paper as we can electronically. You don't get as good of information pushing paper, and you don't get as, it's much more laborious if you're answering the phone and answering questions than if you're doing things on an electronic basis. But we're way behind in the adoption of all types of IT and systems reform. And we know we've got an issue with our systems not communicating with medical systems. Those of you that have figured that out, we need to bring you to our conferences and talk to the industry about doing a better job of finding a way to get their proprietary systems really to connect to medical systems and being able to crosstalk. Frankly, one of the best things that has happened in the last several years that I don't think we focus on, and one of the reasons I wanted to bring it up, is ADA licensing the diagnostic coding system to SNOMED puts everything under ICD. And if we all utilize ICD and the diagnostic coding system crosswalks, we will get the data that we need and that we're all kind of hungering for. But there's a lot of education in getting the carriers to actually use it and collect it, because some of them get it now and don't actually utilize it. So I think that's all part of the role that NADP has with the industry, helping them to understand that that's something that needs to be done. And this big aspirational data project is kind of hanging out there, hopefully that we make some progress toward it. Yeah.
Thank you so much. What a great presentation. I really appreciate it. Also really glad that you touched on the diagnostic codes. So in Nevada, our NCO is Liberty Dental, and they've been in Nevada, what would you say, Dr. Kapura, about a year and a half now. When they started, they required that we use the ICD-10 codes. So we're a school-based sealant program, so that was new for me. And when you started talking about how labor-intensive it is, so we use Dentrix, we're on a cloud-based platform, we have to put in for every procedure the ICD-10 code that relates to that procedure. There's a different code for a sealant versus a prophylaxis versus a fluoride varnish. So the dental hygienists are having to put those codes in. So if you do any data mining, I would go to Liberty Dental because they made it a requirement to get paid. So when your claims are being denied, guess what? You put in the ICD-10 codes because you do want reimbursement. And it's been a fascinating year for us going through this process with Liberty Dental because they were much more restrictive in how they were going to play their game for us as a provider. And it was either you do this or you don't get your claims processed. And everything is electronic. I think that was also a state mandate in Nevada that this year is the first year that we are required to have electronic claim submission to be a Medicaid provider. So that is also kind of new. The one thing you didn't touch on that I wanted to ask about, I see more and more dental discount plans, like Smile Generation. So that information is not part of your dental plans because it's not an insurance. Is that correct?
No. Our association actually uses the term benefits because discount is not insurance. And I think somebody said yesterday that they don't see the rest of dental as insurance, but actually as a former insurance regulator, anything that transfers some risk is insurance. So the only thing in our world that is not insurance is discount, but we do have discount plans and I do have data on them. It's just that because they don't pay claims, and all they do really is, it's like a Sam's Club card. They're giving you access to services at a lower fee, but we do have data on the discount plan, industry along with the rest of dental benefits. So that discount, if you get all the way back to that slide that had all of the columns on it, discounts a line in there. It's 10, I think it's been between 10 and 17 million, so it's not a huge portion of the market, but discount is part of what's counted in terms of population coverage. What we don't count when we don't count the medical plans that have dental benefits subject to the medical deductible, because we don't see that that provides really any coverage. So that's not in the count. So that doesn't count in that 1% or 0.7% you saw at the top. But yeah.
Okay, great information.
Yeah.
Thank you.
Yeah.
Evelyn,
Cass.
great presentation. Thanks so much. You know, I was struck by the discussions that you were describing with the ADA, and I want to have there been any discussions with CODA? Because the notion of diagnostic codes and standardization in that regard is vaguely addressed, if at all, in the CODA standards. And so we're continually in this cycle of producing another 7,000 or so dentists each year who come out of their training without this knowledge. And I think the millennial graduates are much more conversant with the digital world and these types of forms. And it would seem to me if there were more emphasis in dental education in terms of these coding standards, at least it would set the future up in a more optimistic environment, given the fact that, as you mentioned, the externalities, few dentists want to do this. And so, you know, you can at least perhaps have some progress with the emerging generation of newly graduating dentists.
When the big data group got together in the beginning and kind of outlined steps that we should take, that was not part of the discussion. We have tracked some of the work on interdisciplinary training. We were talking about it in our little group over here yesterday. So they didn't bring it up. I wasn't aware that it was, so I'll bring it up to the group. You know, that's part of being here is taking things back to the group and saying, you know, have we thought about this piece of it? And no, the group hasn't thought about that piece of it, but there's no reason why in the scheme of our strategic plan, this one that was adopted that has the big data project in it, started in 2015 and goes to 2020, but we're revising it this year for the primary purpose of making certain that there isn't a gap in what we're looking at in terms of the future for the recruitment of my successor. You know, they want to be sure that if there's some big difference or a different direction we need to go, that whatever skill set they hire is capable of leading us in that direction. So maybe that's the piece. I made a note, and I know where to find you.
Just in your opinion, realizing all the barriers in integrating dental and medical insurance together, what do you think is the potential either that dental would become kind of eaten up by a large copay, or that the caps, the annual caps, or the ability to access more dental services in a more timely fashion might change?
Okay, you want my opinion?
Yes, your opinion.
I don't think the initial solution is integration of the benefits because it doesn't change the delivery of care. And we saw what happened when dental was mandated to be part of small group coverage and the way the medical carriers responded to that. I remember standing up at a DentaQuest Oral Health Alliance conference doing a presentation about, you know, this is coming, and everybody was, oh, this is great, it's going to be in there, it's going to be better, it's going to, and I said something to the effect, be careful what you wish for. These are medical carriers. They're used to a medical universe, they're used to high deductibles, and they've gone even more to high deductible plans. Some of them, to their credit, have put dental into their policies in the right way with a separate deductible, and at least maximums as high as they are now. The interesting thing about maximums, and people say to me all the time, why don't insurance carriers, dentists actually say this to me all the time, have higher maximums? Why don't we have, why has it not gone up over the years? Actually, it has gone up over the years. It's a little incremental amounts. I mean, it's not, the average maximum is not now 1,000, it's 1,500 if you look at our data. We actually sell, the dental insurance industry sells a lot higher maximums. Look at the federal employees program. The most popular policy there is a MetLife policy that actually became the benchmark for the ACA that has a $5,000 annual maximum. So those things are out there. The thing is that 95% of the people don't hit their annual maximum. So there's not much incentive for employers to buy higher maximums that have higher premiums that they then would have to pay a higher percentage of or reduce their percentage and push the premium over to the individual. And there's a cost factor in there where individuals get sensitive about buying more than they feel like they need. So just putting the benefits together means that a medical carrier is going to hire a dental carrier to administer the benefits, because that's exactly what's happened under pediatric, where it wasn't a multi-line carrier that had that capability, and they could just say, Cigna could just say, Cigna Dental, you're going to administer this, and I'm not going to pay you anything to administer it. So there's an added administrative expense and no real differentiation in terms of the delivery of care. So I think there are other things that have to happen. The insurance system, in my mind, reflects the system that it is paying under. So the interdisciplinary delivery of care and where you can get groups of people that, with what Oregon has done with the CCOs, when you can really work with a whole system, you can make that wholesale change. But just putting the benefits together just means the benefits are going to be together. And some of the data actually shows that consumers don't use the dental benefits that are inside of a medical plan. They don't think about it. And the dentists are not also trained to bill medical plans. So you have to kind of set a system up where they go directly to the dental carrier. So I don't think that's a magic solution that's going to change the delivery of care overnight.
Thank you so much, Ms. Ireland. I know we had a few more questions out here, so I'm going to encourage everybody, if you do have follow-up questions, can they come in and talk to you on a break?
Oh, yeah.
Okay, so just come grab her on a break.
I'm not leaving till the end.
Good. So you guys can continue the discussion on a break. But thank you again. We appreciate it. Wonderful.